Welcome back. I'm here with Dr. Humbert and Dr. Delcroix, and in the next section, we're going to discuss real-world PH registries and what do they tell us. Let's ask Mark, what is a real-world registry and how is it used and who's involved?
Well, it's really important to bear in mind that we study carefully diseases like pulmonary hypertension. We are experts and we have data from well-done randomized controlled trials, interventions in academic centers, etc. But the reality is certainly a little bit different from these very pure circumstances. And we need to know more about the condition, pulmonary hypertension. We need to know more about real-life studies in that setting, and the data can come from many people. It can come from the patients themselves, it can come from the doctors and healthcare providers, it can come also from researchers and from clinical trials. But what we really like to have, and we worked a lot in the last 25 years in terms of registry, we really want to know exactly what is the current status of the condition pulmonary arterial hypertension in real life, what is the real severity of patients, what are the comorbidities, what is the management, what is the outcome, what is the quality of life of the patient, and do we have interventions which make these conditions better in real life setting. So the real life registry complement the current clinical tools we have in expert centers and with randomized controlled trials.
Excellent. Marianne, can you provide some examples of registries and how they're being used?
Yes, of course, and I think we need to acknowledge the start of this registry through the US NIH registry, which was concerning only idiopathic PH at this stage, and you know that the knowledge we had from the disease when we started, I think Mark and me, was completely based on this registry data, and so when we see the years after, there has been the start of the French registry, of course, which was one of the key moments. We had then Spanish registry. We have the Reveal, of course, who included a lot of US patients. We have some registry in China. We have them in UK. So we have a lot of national registries. We have few international registries at this stage. And all of them provided data on the epidemiology of the disease, the symptomatology of the disease, the outcome of the disease. The more and more are giving us also now information about the effect of drugs. And one of the main information that we have on that the patients are not corresponding anymore to the patients we are including in the study. That's a very big problem. Anyway, you have this information that we have in the large registry, very good data on incidence. We know, thanks to this registry, that we have a prevalence of pulmonary hypertension, which is probably in the range of 50 cases per million inhabitants. We know that the survival of the disease is still an important point. We know that there is about 10% mortality per year globally in the patients with pulmonary arterial hypertension. We see also that most of the patients, in fact, are at intermediate risk, and we are not reaching low risk stratification in the majority of the patients. So we have gained such a lot of information. The pity is a bit that the information we have on the patients with comorbidities and so on is not driven by randomized controlled trial, and we still are completely unaware if, for example, giving monotherapy to these patients is the right strategy. So it's a disconnection which is posing more and more problem, that the studies looks at patients without comorbidities and that we treat the majority of the patients with comorbidities. But anyways, this registry are provided the most of the knowledge we have on the disease.
The Compara registry is one of note that looks at the different clusters. Can you comment on how they did this analysis, Mark?
Well, indeed, Compara and the Swedish have been very clear that patients in the pulmonary hypertension registries were not as classic as they used to be in the very first NIH registry or in the very first year of the French registry. And with a cluster analysis, the Compara colleagues, including Marion, who is sitting with us, they clearly showed that you have a cluster, which is a classic cluster, which is a group of patients who are younger, more female, with no comorbidities. And these patients have not smoked, or they have smoked very little, and they have no abnormalities or no major abnormalities in gas transfer. So that's really important to emphasize that this cluster still exists. It is enriched in the randomized control trial, and it was almost the only one in the first NIH registry. Then you have the two other clusters which are important to highlight. One is a cluster made mostly exclusively of females with cardiopulmonary comorbidities, including obesity, including diabetes type 2, including hypertension, and no smoking history. And in these ladies, the DLCO is mostly above 45% of a predicted value. And this cluster 2 corresponds to patients with significant cardiopulmonary, with cardiac comorbidities. And these ladies are in their 70s. They are not young ladies. The third group is mostly males with a smoking history and comorbidities as well, and a very low DLCO. And these patients have cardiopulmonary comorbidity. So it's interesting to show that the classic cluster still persists, but it is surrounded by two very vast groups of patients with cardiac and or cardiopulmonary comorbidities. And these patients with comorbidities are less likely to respond well to treatments, and you need to keep an eye on their response to therapy.
Something I think that we see in the clinic every day, right? Where the patients that are the textbook phenotypes are those that are expected to have really responses as defined by the trial that got the drug regulatory approval. And the others, it's almost like an experiment. You wonder, you're guessing that if the drug is going to work at all.
Indeed, and we don't say you don't have to treat the patients, and we say you have to keep an eye, you have to be careful, you have to treat them well, follow them carefully. So I think it's really important, as you say.
One of the calculators that is available online and that a lot of US sites use is the Reveal Lite. So it is a shortened version of the Reveal Registry calculator that has become a little bit more practical for use and therefore has been adopted. I use this in addition to the French low-risk criteria as an integral part of every note that is written for the patient in follow-up in our clinic. Are you using Reveal Lite? There certainly is an app, there's an online calculator in your clinic, or are you focused, obviously, because the data for the French registry is so important that you're limiting your calculations to just to one assessment?
Well, because you mentioned the French, I think the question is for me. So I think you are right. I mean, we use the scores, and we don't oppose the score. I think the key message is you have to measure risk, and irrespective of the test you use, you have to measure risk. And Reveal Lite 2 is certainly a very good scoring system, and it's very close to the French scoring system. So I wouldn't say I use this one versus this one. In the French registry now we include Reveal Lite 2, and it's very very informative. But the added value versus what we use on a daily basis is minimal. So we don't say it's better or worse. We just say that the added value is minimal. But the key lesson to the people who listen to us, you need to risk stratify your patients at each visit in order to see if they are on the right side or on the wrong side, and whether you need to consider a modification in the management.
Mark, that brings up the concept of the gestalt and whether or not even an expert can correctly identify the risk and the severity of the disease, if you will, prognostically for the patients. Marion, do you feel that you can assess a patient without formally doing a risk assessment?
Well, I would say that this risk assessment is clearly useful. So sometimes when you look at the BNP, when you look at the 6-minute walk, you are finding things that you would not have expected. But to complement a bit what Mark said, I think the reveal light is not giving us so much more than what we have now with the 4 strata. What I sometimes like, and this, as you can find also in the guidelines, is to have the complete reveal for patients where we are thinking about transplantation, because it's very useful to explain to a patient why we do this big step to looking for transplantation, when you can show them all of the things who are not what we would expect them to be. And so this is, for me, the best place of the reveal.
Let's move on to the PHAR registry. This is a registry that comes specifically from centers that are in the US accredited as centers of excellence in the PH space. And in this analysis, they talk about portal hypertension and disparities that relate to college graduate yearly income and unemployment status, and showing some statistical differences. Are there attempts to look at disparities, at health disparities in Europe? We'll start with Marion.
Well, not yet. So beside the guidelines, there is a paper coming out on the quality indicators, which are important for the follow-up of patients with PH, the follow-up, but also the structure of the centers and so on. And I think this will be the base to look at this data, and then we will be able probably to discriminate what is the best place for the patients to be followed.
It's an issue of access, I think, for many in this country. In France and in Europe, I think in general, patients have access no matter what their socioeconomic status. The question is whether they can activate that access. Are they available? Are there disparities in France?
Yeah, no, it's a very good point and a very interesting discussion. In Europe, as you know, the solidarity and the social system give access to everyone to any kind of drug if they are approved and reimbursed. And our friends from Scotland have studied people with a lower socioeconomic status, and they have showed that there was no prejudice, and that they were treated the same way than the people who come from a better social status. So I would like to say that, of course, in France, people who have a more difficult background, they have other reasons also for being less responsive to intervention, etc. But the treatment itself, the specific treatment of pulmonary hypertension, is similar in any social status people. Giving access to the social status is very simple in France. When you are born, you have your number and you will die with it, and you have access to the drugs. Of course, you need to be treated with a diagnosis, and maybe that's where some people fail, because they don't complain, they don't go to the right place to be identified and diagnosed and treated. But we have a very strong network. We cover the full country, and in each region there is an accredited commission center which have access to all drugs. So I would like to think, maybe I'm a dreamer, but I would like to think that the access is good.
Dreamer is a different definition in the US, but definitely we would definitely like to have dreamers in your realm and have the same access in the US, which unfortunately we don't have. What do you think, Marion, are the challenges and limitations of PH registries?
Well, a lot related to the methodology. So we have in Europe, as you have perhaps heard, we have the European reference networks, which are designed to help and to homogenize the treatment of patients with rare disease. And so we see in this initiative that we have between countries, within countries, we have a large problem of interoperability. We have also problems to get the same parameters because all the registry have their own design. So this is something which is important. We have also big problems now with new regulation concerning data protection in Europe. So these are important parameters. We have also problems for maintaining the registry. Many of them are sponsored by industry, and sometimes the industry is saying, okay, so now we stop while we still want to collect data. So there are really a lot of limitation, but I think that's the best way to get data anyway.
So let's just summarize then what we've talked about. Both of you have talked about the importance of registries and how the real world actual presentation in the clinic may be different, very, very different sometimes than what we see in randomized controlled trials. Registries are the ideal tool to use for the determination of the best way for caring for patients within that sector that they lie in, within the country, within the region that's being studied. And also these observational studies are important in addition to randomized controlled trials for the detection of rare or late adverse effects or treatments, things that we may not see with the usual regulatory pathways for phase 4 follow-up of these drugs. We know that registries should advance knowledge while ensuring patient privacy, as you just said, Marion. Privacy in particular in Europe with new regulations is under much scrutiny, and I think it's only going to get worse before it gets better as people in the electronic age continue to share more data and as those that try to thwart the system and break into it get more and more skilled. There's optimism to integrate new technologies and data sources into future registries, and I think that hopefully that'll make it safer and more relevant and more useful in improving outcomes. Thank you again for joining us, Dr. Marion Delcroix and Dr. Marc Humbert. It's been my pleasure to have you weigh in on all of these important facts and summaries for treatment, diagnosis and treatment of pulmonary arterial hypertension.
Thank you very much.
Thank you.